Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they'll be addressed. I'm honored to introduce our mentor for today, Dr. Qamar. Dr. Qamar is the president of Children's Medical Group at Ocala in Florida. She completed her pediatrics residency at Bridgeport Hospital and Yale New Haven Hospital in Connecticut. Dr. Qamar is passionate about giving back to our community and works on many humanitarian projects in the DC, Maryland, and Virginia areas. And now it is my honor to request Dr. Qamar to begin today's session. Thank you.
Assalamu alaikum, everybody. Thank you, Minahil, for the introduction. So I'm a pediatrician in Ocala, Florida. I do general pediatrics, and I did my pediatrics training in Connecticut. Like Minahil mentioned, I've been in private practice for 24 years now. This is actually my 24th year. So I thought I will talk about, I want this session to be more interactive because I feel like kids learn more when they can, it's more interactive and not just one person talking. So I'm going to present my presentation and then I will take questions from you guys. So basically, what I'm talking about today is the COVID-19 vaccines in pediatrics. As you all know, in USA, the COVID-19 vaccines have been approved for usage. They were initially given, the Pfizer vaccine was given the emergency FDA authorization, but now it's the regular authorization. So I'll talk about that in a little bit, but basically the COVID-19 vaccine is now recommended for 6 months to 18 years of age. That's the typical pediatric age group that's considered all the way up until 18 years of age. So let me go ahead and start talking about that. So there are 4 types of vaccines that are currently approved for kids. One of them is the Pfizer vaccine, which is called BioNTech. Then the Moderna vaccine, which, as you know, is Minahil has pulled up the first one. So this slide I'll talk about in just a little bit. The third one that's recommended is the give me 1 second. Let me pull up on my screen also so I can see better. Give me 1 second, please. So the third vaccine that is recommended for this age group is the Johnson & Johnson vaccine, but which has been taken off the main immunization schedule for side effect of thrombocytopenia and thrombosis in kids. Although the incidence is very low, was found to be 4 cases in 1 million dosages administered, but because of the pediatric age group, it is not the primary vaccine recommended anymore. And the two main, and the third one, and the fourth one is another vaccine, which is the Rho vaccine, which I will tell you in just a little bit. All right, so the Pfizer and Moderna vaccines are the messenger RNA vaccines. The Novavax vaccine is a protein subunit vaccine. And then Johnson & Johnson is a viral vector vaccine. And like I said, the Johnson & Johnson is the least favored vaccine in USA right now. These vaccines do not have any preservatives such as thiomersal or mercury. No antibiotics, no therapeutics are included in that. It's not a tissue. None of these are tissue vaccines. They are not egg-based. And no metals such as iron, nickel, cobalt, or rare metals. And most importantly, no latest vaccines. So the vial stoppers that are used to store these vaccines, the vials, do not contain latex. And the good thing is that after the body produces an immune response, it discards all of the vaccine ingredients, just as it would discard any substance or cell that is no longer needed in the body. So this process is a part of normal body functioning. So I always tell it to my patients because especially initially, this is a relatively new vaccine. Parents had a lot of concerns. There was a lot of misinformation in the media about this vaccine having aborted fetal cells or egg proteins or metals which can permanently get stored in the child's brain and cause all these issues. So it is important to tell the patients that the vaccines that are currently administered do not have any of these. So as you know, the messenger RNA vaccines are the most widely used vaccines right now, which are made by Pfizer and Moderna. So they're created in a lab to teach our cells how to make a protein, or even just a piece of protein, which triggers an immune response inside our bodies. And the messenger RNA from the vaccines is broken down and is discarded from the from the body. The Nova vaccine protein is a protein subunit vaccine. This vaccine contains pieces of the virus that causes COVID-19. So inactivated, remember, these are all will be an inactivated virus. So the virus pieces are the spike protein. As you know, the COVID-19 virus has spike proteins on it. So what they've done is they've taken a small part of that protein, and that is what triggers the immune response, which I'm sure you are all familiar with, that it perceived as a foreign antigen by the body, and an antibody response is mounted. After learning how to respond to the spike protein, the immune system will be able to respond quickly to the actual virus protein and protect against COVID-19 vaccine as needed. The fourth type, like I mentioned, is the Johnson & Johnson vaccine. This one is a viral vector vaccine. So these are harmless. What they do is they take these viruses, like harmless viruses, and they use as a vector. And so these are not the COVID-19, but it's another virus. And then the vector virus delivers important instructions to our cells on how to produce antibodies. Okay, so now a commonly asked question is, how well are these vaccines working? People who are fully vaccinated have lower risks of severe illness, hospitalizations, and death from COVID-19 vaccine. As you all know, this is a very clever virus and has mutated several times from the time it was initially identified. So basically, it is important for us to tell our patients that these vaccines are not going to protect 100% against the virus, because the original vaccine, since then, the virus has mutated several times. So I always tell my patients that don't expect it to provide 100% protection. No vaccine does that, especially this clever virus, because it's mutated so many times. So the most recent subvariants, the BA4 and the BA5, which they're called the Omicron subvariants, that are currently circulating in the USA and much of the world, are very closely related to the original variant, but not the 100%. So also, it is important to know that the COVID-19 vaccines have undergone and will continue to undergo the most intense safety monitoring in US history. And the US government is keeping a log of all the vaccines that are administered, and the billions of vaccines administered globally, and they have been shown to be safe and effective. Side effects that can happen, like with any other vaccine, that happen within 7 days of getting vaccinated, are common but mostly mild: fever, chills, headache, tiredness. Most common after the second dose of the Pfizer, Moderna, or Novavax vaccine. As you know, the first dose starts, to elicit the antibody response. So when the second vaccine, the second vaccine of the series is administered, is really when most of these mild side effects happen. So what are the severe allergic reactions which can happen? Like with anything else, Nothing is 100% foolproof in medicine. There was also some, I'm sure you guys all read about it, that there is reports of myocarditis and pericarditis, especially among males ages 12 to 39 years of age. So what they did was that they increased the interval between the first and the second dose to minimize the side effects. And these side effects happened with the messenger RNA vaccines and were also reported with the Novavax COVID-19 vaccine. And then I just talked about it, that the Johnson & Johnson vaccine is the least favored vaccine right now in the US. And that is because it is associated with blood clots, with low platelets, thrombosis, with thrombocytopenia. It's called TTS syndrome, which is thrombosis with thrombocytopenia syndrome. And it's very rare. It happens, so far it has happened about 4 cases per million dosages administered, but has resulted in death. So that is why we don't recommend the Johnson & Johnson vaccine as a preferred vaccine. So, as with anything else, we have to make sure that the patients understand the safety and efficacy profile and they feel comfortable with this, especially with pediatrics. As you all know, that parents can get very touchy about it, and they want to make sure they can take risks for themselves, but not for the kids. So these are all good, resources that we need to tell our parents. In my office, I have handouts. So I give these handouts to parents, and so that they read about them, they feel comfortable, and then they come back and get it. When the vaccines were initially rolled out, private pediatric offices were not given these vaccines because of the sheer number of people that needed to be vaccinated. But now we can. So I have ordered vaccines from the health department, and what they do is they provide me monthly vaccines. And the only thing is that each vial has 6 dosages in there. And once you open a vial, you can only store it for 24 hours. So we have to have people scheduled ahead of time so that when they come in to get the vaccine, I can give at least 6 vaccines in one go. So now let's move on to I'm going to talk about the actual, can you please scroll up a little bit? I want to show this one. So if you guys all look at this, can you please pull up to table 1? This is it, yeah. So I'm going to start off with the youngest age and just work my way up to the older kids. So currently there are 2 types of vaccines available: monovalent vaccine, which was the original vaccine developed. And now this year, since middle of September, we have started getting the bivalent vaccine, in which both Moderna and Pfizer have included the Omicron subvariant BA4 and BA5 in their vaccine. So these are called bivalent vaccines, as opposed to the monovalent vaccines. So if you look at this thing, you can see that the 6 months and above, both Pfizer and Moderna are now approved. Novavax is not. Novavax is the protein subunit vaccine. It's only 12 and above. So 6 months through 5 years, and then there are different age groups that are divided up. So you can see, people often ask me, what's a primary series and what's a booster? So for both Moderna and Pfizer, the primary series consists of 3 vaccines, not 2, 3. And then the booster is the 4th vaccine, because there's sometimes confusion. Okay, I've already had 2. Why do I have to get 3? Because that completes the primary series. So there are primary series and then there are boosters. So if you look at it, the 6 months through 5 years of age for the Moderna vaccine, the interval between dose 1 and 2 is at least 4 to 8 weeks, For kids, for little ones, I'll be honest, I'm preferring an interval of 8 weeks. And then the interval between dose 2 and 3 is also at least 4 weeks. So then similarly, if you go down monovalent Moderna, 6 through 11 years, again, dose 1 to 2, 4 to 8 weeks. And then the third dose between second and third, 4 weeks. Then 12 through 17 years, again, monovalent Moderna. This will be, so we are still on the primary series, which will be at least an interval of 4 to 8 weeks between 1 and 2, and 2 to 3, 4 weeks. And if you scroll down, if you look at the Pfizer for 12 to 17, that's the earliest who have been recommended to get the bivalent vaccine. And the interval between the third and the fourth dose, which is considered the booster, will be at least 8 weeks. And similarly, if you look at so we just talked about Moderna. The Pfizer is pretty much the same. Pfizer divides up their age groups a little bit differently. So their first age group is 6 months through 4 years, then 5 through 11 years, and then at 12 through 17 years. Same thing, dose 1 to 2. As you know, the dose 1, the interval for Pfizer between 1 and second dose is 3 weeks. But because of this concern, especially in males with the myocarditis and pericarditis, I recommend that they wait 8 weeks between the first and the second dose. And then the second and third dose, also 8 weeks. So it's a little bit different than Moderna. And and then 5 through 8, same thing. And then 12 through 17 can get a booster. Again, please remember the booster is dose number 4. Is you can wait 2 months, which is 8 weeks. And you can give the bivalent for Pfizer only, not Moderna. You can give Moderna also can give 12 and above can get the booster with the bivalent with the new variants included in that. That's what everybody is getting right now in the country, because everybody got the primary series pretty much early on in the year. A lot of parents ask me, how much do they have to wait before, like if they get the COVID-19 actual infection, how long do they have to wait before they can get the vaccine? I mean, really, if the studies show that as early as 4 weeks after an infection, the IgM has tapered off, and then these vaccines are going to elicit the IgG response anyway. So I usually say wait at least 4 weeks after your infection before you can get the vaccine. So what I'm saying is that having the infection in between should not preclude the patients from completing their the vaccination schedule, because a lot of parents assume, oh, my child already has the COVID now, so I don't need to complete the series. So I always tell them, I know it's very tedious and the parents don't want to hear it, but they need to finish the series, the primary series, and then the booster. Then, so right now, everybody in the USA is getting the boosters. For 12 and above is going to be the bivalent, and 12 years and less is going to be the monovalent. Now, quick reminder that the babies 6 months through 5 years, we are not giving boosters. They're only getting the primary series. The booster is being given to 12 and above. So 6 months to 11 years, only the primary series. 12 and above can get the 3 primary series and then the booster. If you move down a little bit, Manahil, please. I just want to make sure that I talk about the second part of it. Manahil, are you there? Okay, here we go. So this just completes what we just talked about, the primary series and booster. It is important to know the difference between these. You can see that the adenovirus vaccine, which is what we talked about, is different. Moderna, Pfizer, Novavax can only be given to 12 and above. It's a protein subunit vaccine. And then dose 1 to 2 is at least 3 weeks. And can you go down to another one more time, please? So this is just basically talking about what we talked about already. These are useful things, to like handouts to give to the parents also, so they can actually read. Because a lot of times, as you know, when you're talking to patients in the office, they may not understand what we're saying fully. And, this is new information for them. So I always give out handouts, and I always tell them, these type of figures and stuff. So you can see that Moderna, at least 4 weeks apart, Pfizer, 4 weeks apart, and then the third dose is at least 8 weeks. And you can interchange these vaccines, because another thing that people ask me is, how to make sure that they're, complete the vaccine. So we don't, as long as they met the minimum requirement with the interval, we use them interchangeably. There are some, if you scroll down, there are some like finer print about what to do if the child has, like, say, if the child started the series at age 6 months, and then they go down, and then their birth rate comes. So we always take the lesser age for that. This table talks about, again, the different types of vaccines. And you can see that they come in vials, so you don't have to put any diluent or anything in there. That's another thing that used to bother people. Moderna does not have any diluent. I mean, these are more technical issues. The parents just want to make sure there is no contamination with, mercury. As you know, there was a big thing in USA about mercury and causing, in MMR vaccine, causing autism. So it's always good to reassure parents. I think there's one more table at the very bottom. Or is that it? Okay. So one quick thing I want to talk about before we move to question and answer is the immunocompromised patients. The immunocompromised patients, especially, as you all know, are most vulnerable to the COVID-19 virus. And hence, we want to make sure, in fact, before the FDA approved the all of this for the general population, kids who are immunocompromised were given these vaccines before. None of these vaccines are live virus vaccines. So kids who are on immune therapy, chemotherapy and immune therapy and stuff can get them. As you know, with MMR and chickenpox, these are live vaccines, so cannot be given to kids with immune compromised immunity. So obviously you always try to vaccinate the most vulnerable first, which includes pregnant women, young kids, immunocompromised kids, and then you move to the other. For us in USA right now, asthma season has started. So these kids are also very, very vulnerable to serious complications of COVID-19 vaccine, like pneumonias and stuff. So we are emphasizing right now, and the flu season has also started. So I'm telling all my parents to get their COVID-19 vaccine as soon as possible, and the flu vaccine as soon as possible. A lot of parents ask if they can get the COVID-19 vaccine and the flu vaccine at the same time. I am discouraging it right now, because this is the first season that we are recommending both the vaccines for kids, healthy kids. And I really want to make sure we have some data before we make sure. There's some talk of combining the flu vaccine and the COVID-19 vaccine in the future. So with one jab, the kids will be able to get both the vaccines, but right now they're given separately. So I'm telling my parents to separate the two by at least, a month, 2 weeks to 1 week to 2 weeks. So they're not being given at the same time. I think that's it. This is just a basic, very brief introduction of COVID-19 vaccines, their availability and their recommendations. And I'm happy to answer any questions.
Sure. Thank you so much, Dr. Qamar. I really appreciate your time and teaching. We'll now switch over to our Q&A session with Robin.
Hi, I'm Robin. I'm a graduate student at Johns Hopkins in the School of Medicine. So I'll start our Q&A session. So you've talked a little bit about side effects in general. What were some of the most common side effects that were seen in the pediatric population? Were they the same kind of aches and pains and fevers, things like that, like the adults?
Yes. Basically, the main thing was like, the low grade fever, especially after the second dose, headaches, generalized malaise, and then it seemed like they were different for each child, but all of them were mild. And there are some studies that show that we don't want to suppress the immune response, the fever, very quickly. So whenever I give, we give the vaccines in the office, I always tell the parents to wait at least 8 hours before using any antipyretic like Tylenol or something. So yeah, they were pretty much mild side effects.
Can you explain what the reason is for the variation in vaccine response? Some people seem to feel pretty miserable and some people don't have much side effect.
So it seemed like, we all have different immune responses. I'm sure you all have read about the studies about how some people have managed to escape COVID-19 infection, visible infection. So we really don't know, but there are some, as you know, that the COVID-19 vaccine is a coronavirus, right? And it's the same virus that causes common colds and sniffles in the winter months, has been happening for years in kids, right? So there is some immunity, and some kids carry that immunity more than others. So that's why if your baseline immunity to generalized coronaviruses is more, you will have less of a side effect. Versus if you have your baseline immunity is less, then you will have more fevers and aches and pains because your body will have to make more immunity versus less immunity. That's in a very nutshell, very basic. Similarly, that explains why some kids and adults, even though they're exposed, multiple times, very close exposure to COVID-19, have not developed overt infection. Same concept. Because they have been exposed in the past, they have immunity in their system, and if you run IgG and IgM on these kids, sometimes IgGs are coming back positive. So that they have, they were exposed, they have it, but they just don't show any symptoms. So I think it's just a matter of the intrinsic immunity, how well it was developed and as babies, they were exposed to coronaviruses.
So continuing along this line of side effects, what are some complications that you've seen in patients or differential complications between the mRNA vaccine versus the adenovirus vaccine or the protein subunit vaccine?
So in my office and all the pharmacies and health departments, the usual source of vaccines that the kids are getting right now, majority of them they are getting in their in the health departments and the pharmacies, because they have the capacity to vaccinate way more than we can in our pediatric offices. But having said that, the most common scenario I've seen is that the kids who are getting vaccines are 99% are the ones with the messenger RNA, Pfizer or Moderna. So sorry, I think I got muted. So majority of the kids I have seen are getting the messenger RNA vaccines. I've never recommended because of the aforementioned side effects with the thrombosis and thrombocytopenia. I don't recommend Johnson & Johnson, even in young adult males, because they're impatient and they say, oh, we want to just get one vaccine. And I say, no, it's not going to be of any use to. So I have not. And this Novavax, the one which has the protein subunit, I haven't really recommended to anybody. So the 99%, like I said, are the kids I'm giving them or recommending messenger RNA vaccines. And the safety profile for both the Pfizer and Moderna seems to be pretty robust. And it seems like most of the studies that I've come across also focus on these two vaccines. So they're pretty safe vaccines. like I mentioned, the safety profile is pretty comparable, Pfizer and Moderna both. And whenever patients come to me and they ask me which one I prefer or which one I recommend, I say both of them are equally effective. So you go for the one that you have easy access to, whether it's the health department or it's the, the private clinics.
So we've all seen those rare cases of vaccine-related myocarditis in the news. Can you explain a little bit about how that might happen or why it's more prevalent in young males?
So between the ages of 17 and 39, there were some studies that show after the vaccine, and it has to do, I think, with the way the body is reacting, the antibodies that are formed. It seems like in these kids, like I said, mostly males, the vaccine does elicit some sort of an autoimmune response, and hence affecting the heart muscle and causing myocarditis and pericarditis. As far as exactly what is happening at the cellular level, we're still trying to figure that out, but broadly, that's what the rationale is, that the autoimmune response that is elicited from these vaccines is somehow attacking I shouldn't use the word attacking because that's very aggressive and parents get scared when I use, so I don't use the word attacking, but it seems like the antibodies will go and settle in the heart muscle. That's how I put it to the parents. And I say, but the good thing is it's transient. But just so that we know, and any child who calls me and with any type of chest pain or something, I always ask, did you get the vaccine in the last 4 weeks or so? And if they say yes, I always send them to the ER to get an EKG and echo done. And if it shows anything, as you know, there's nothing much, we just follow them and make sure the EKG and the echo gets repeated, and they do fine. There were some reports from this Johnson & Johnson vaccine causing, I think, some mortality in South Africa. But in this country, I have not come across any reports of kids dying from the pericarditis and myocarditis. By the same token, I wanted to mention something which has not been discussed very much in regards to the vaccine, but that has been shown that it is causing change in menstrual cycle in girls, the vaccine. So it will increase the menstrual cycle. It does not change the intensity or the duration of the menstrual flow, but it seems like it is delaying it a little bit, like increase, by 1 day. And there are enough studies out there now. We have enough, so us to show. And I always tell, my female patients when they're getting it, that this is one of the things that can happen. Again, it's transient, and it does not cause any long-term side effects with the fertility or anything, but it's just the menstrual flow changes a little bit. The duration stays the same. The intensity of the flow stays the same, but it just gets delayed by average of 1 day. So it's always good to talk about these ahead of time so they get a little bit reassured. So this is another thing that has been found from the vaccine.
So some of the vaccines you mentioned are linked to changes like ischemic changes and blood clots, things like that. Would that have anything to do with the changes in menstrual bleeding, or?
So the Johnson & Johnson, which is the vaccine, which is the, with the vector virus, right? That is the one that has been shown to cause the serious side effects of thrombocytopenia and thrombocytosis. And that has been shown to cause, so somehow it is, I don't think, because if it had anything to do with causing increased bleeding, if we found out that there was like intensity of the bleeding was more or prolonged, I would say, yes, it could probably in the same category, but this one is just getting delayed by 1 day. Versus the Johnson & Johnson, the TTS, the thrombocytopenia thrombosis syndrome, is actually causing thrombosis. And again, it has been, like I said, it's only 4 cases in 1 million dosages, but was enough for everybody to get scared. They did cause 1 death in South Africa. So the vaccine was not withdrawn because of the safety concerns, but still there. But it does merit mentioning. And I usually tell my parents to not give Johnson and Johnson. So it seems like it's causing, again, the same thing seems to be the underlying thing seems to be autoimmune. To me, that's the one common theme I'm seeing, we're thinking. Autoimmune would, that would tell us what's happening. Maybe, who knows, the vaccine is attacking the ovaries and making the period start a little bit later. Again, the autoimmune part of it. Or, I don't think it has any central effect coming from, the FSH, LH is not being affected. I think it's mostly related to the local effect on ovaries. Similarly, the way it is affecting the heart of a young male by means of autoimmune response, which is temporary, benign, maybe scary for the parents, but good thing is not in any way causing permanent problems or damage.
So in terms of a potential autoimmune reaction in the ovaries, would recommendations be different for a patient who already has like polycystic ovary syndrome?
I don't think it's gotten to the point where, like I said, everything is very preliminary right now. So it is being studied. A study just came out which talked about this. It warned the women. In fact, I think it was in New England Journal of Medicine. So we are not to the point where we can make specific relation changes to like polycystic ovarian syndrome and stuff. But remember, this is again a speculation at the cellular level. What is happening, we don't know. So I think it's a little bit early, but certainly this is something we need to look at, because I mean, this is anecdotal and not something which has been studied right now. The one that's studied is the menstrual flow, and then in males, the pericarditis and myocarditis. But one of the things that my patients have told me is that after the vaccine, females seem to be complaining more of lower backache. I had, at least 3 different patients complain of the same thing. I had x-rays done, nothing showed. And then after about a few weeks, it just seemed to go away. So that's another area. So there is some autoimmune stuff, not everybody, very rare, but still enough to merit mentioning. So I think we'll have a little clearer picture. Good thing is it's been studied very, very scrupulously right now and openly. So we should have some information, I would say, in the next 6 months or so, after this COVID-19 season is over, which is starting now. Will usually, like the flu season, will last from fall to spring. So once this spring of 2023 comes, we should have more, because any type of adverse effect gets reported to the VAERS vaccine adverse reactions. It's a registry that we all follow. So once we get enough information, then we'll have a better idea of what is happening at the cellular level. Right now, there is no recommendation to change anything for girls with polycystic ovarian or anything.
I think that's been one of the most fascinating parts of this COVID-19 pandemic. We've really been able to see the scientific community come together. And I think people for the first time are probably seeing science in real time, because people are really trying to get results out much faster.
Yeah, absolutely. And the messenger RNA vaccines, it's a brand new technology, right? I mean, it has been known for a while, but nobody was using it in mass because people were so scared of it. Now we know it's a tremendous thing, which was underutilized in the past. It increases the speed of making vaccines. Nobody could have imagined that we could have a vaccine in 6 months. Before the XL vaccines and even the viral vaccines, vector vaccines and stuff, you had to wait years to develop. But now it seems like within 6 months, so messenger RNA vaccine, and that's why people got so scared of it. But I think it's a tremendous improvement in, scientific method, and very fascinating. Yes, I agree.
We had someone from a pharmaceutical company come to give a lecture in one of my classes, and he replayed a clip from a lecture he'd given a few years ago about how he thought that messenger RNA technology was the most promising thing, but it would never happen. Like, no one would ever have enough confidence in it for us to be able to use it. And now, just a few years later, it's amazing and it's actually gotten this platform.
Thank God we had that technology and we were able to mobilize in such a timely fashion to get vaccines out for the COVID-19. Otherwise, if we were following the good old egg vaccine, it would probably be like, at least 2 years versus, so the duration of making a vaccine has dropped to 6 months, which is amazing.
So a little more generally, if you have patients that are suffering with autoimmune disorders, how do you decide which ones are able to get a vaccine?
So I have, like if when the patients come in and somebody like, are on immune therapy or chemotherapy or something, and there are not enough studies or have some sort of immune disorder, like, TTP, thrombocytopenic purpura or something, I'm telling them to wait a little bit for the same reason that I want them to wait at least another 2-3 months, 4 months. So at least we have some more data. I've told them, I said, look, I'll be honest with you. This is something which is potentially there, has not caused any serious problems. You decide. If you feel comfortable, you can definitely go ahead and get the vaccines. But, if you can wait at least another couple of months or so. So because this is on, like daily we get new information. So I tell them maybe wait until end of October or so. And I can tell you a little bit more what we have found out at that time. And, so we'll call them back. I do call them back. We have a running list of patients who are waiting to get vaccinated. So I'll call them and say, or if they're being followed by the, immune clinic, allergy and immunology clinic, I usually pick up the phone and ask them. I said, okay, how much data do you have? Are you comfortable recommending what's going on with this patient? And they'll be honest and say, look, we don't know. And we have told the patient, then, they can wait a little bit. But, people are already suffering, like I just said, who have these issues with blood clotting and stuff. Definitely no to the Johnson & Johnson vaccine. Possible yes to the mRNA vaccine. But then again, it has to be the comfort level of the parent. Some of the parents don't feel comfortable, and I don't want to force them or, belabor the point at that time.
So this is probably more of a kind of FDA technical question, but the new bivalent vaccine is still under emergency use authorization for patients like 0 to 3 years of age. When does it gain full approval? Is it just a period of like you have to wait a certain amount of months or have a certain amount of data collected?
For pediatrics, there is a lag of 1 year right now for all these vaccines. So if you remember last year, we all got the vaccine. Beginning of 2021, we got the vaccines, right? It was approved and we all got the vaccines. But we didn't approve. The FDA gave emergency approval in summer of 21 for older kids. But for the little guys, we just got the recommendation 6 months and above. Now, I think 2 months ago, we got back. So right now, the way it's running, there is a lag of at least 1 year between 12 and 17 and adults, and 6 months and 5 years. And then 5 years to 11 years is another age group. But so the 6 months to 5 years seems to be the one where there's the most hesitation. And so right now there is a lag of a year between older kids and 6 months and 5 years.
What pediatric age groups have you seen the most COVID-19 positive cases?
Actually, all of them. Now COVID-19 is basically just like a cold, So they come in, and one of the differential I follow now is COVID-19. Because before they were, we won't even test them. We would just say, oh, it's a common cold, rhinovirus, whatever. And you just do the fluids and stuff and take vitamin C and just stay home until the fever is gone. But now, if for these symptoms like rhinorrhea, cough, nasal congestion, even like low grade fever, like 99 fever, that typically was associated with the rhinovirus or the coronavirus, like is the same as COVID. So now I do check them for COVID. The only time I don't check for COVID is if the child is homebound and there is no, adult with any type of underlying condition and stuff. And the parents say, nah, it's fine. We don't need to get it. I offer it to everybody. But the kids who are in school, I do check for COVID. And the reason for that is that we don't know who they're going to infect in turn. Not because they're sick, but because we want to make sure that parents are equipped and the schools are equipped with more information. So I do run this and the COVID test, and I would say at least 20 to 30% test positive for COVID. So like say if 10 kids showed up in my clinic with these symptoms and I ran COVID-19, and remember I do I don't do the PCR in my office. I do the antigen, rapid antigen. So if I do the rapid antigen on 10 of them, at least 3 will be positive for COVID. And then I can, write them a note. Okay, they have to be excluded from school, or the parents will know, and then, or they can if they have grandparents in their household who are sick or something, then it's good way for them to know and make a plan for that.
So that's an interesting point. Young children have been pretty sheltered. I mean, they've been doing virtual school, they've been isolating, we've been wearing masks. Now that things are going more back to normal, have you seen a burst in other regular childhood diseases?
This year we are supposed to get a more severe flu virus. Flu season anyway. Last year, as you know, the season fluctuates. 1 year is very severe, 1 year is, okay. So last year the flu virus was either neglected when it didn't check enough, or it was not a severe flu season at all, because everybody was so focused on COVID-19. This year, they are predicting a more severe flu virus the season. As far as kids getting exposed, in Florida, where I am, they've been back in schools for the last 2 years. They were asked to wear in 2020. They were asked to wear. They started school back in August of 2020. They were asked to wear face masks and stuff. And 21, they took away the recommendation for even face masks. So I don't necessarily see an increase in upper respiratory infection diagnosis in kids, but I definitely see an increase in COVID-19 since they've been back in school, either because we are checking more, or maybe there is an increase. Because remember, unless you check, you don't know if a child has COVID-19, right? They come in with like just a little sniffles, and some of them don't even run fevers. And so you say, oh, you're fine, go back to school. But maybe they have the COVID-19 virus. So that's what I'm saying. So it's not necessarily that the cases may have increased. It may be because we're checking more.
So kids seem to have these pretty mild infection symptoms. Why do you think the mortality rate is so much lower in pediatric populations?
I think for the same reason that I was mentioning, that the kids are the ones who get the most URI infections, right? As far as, from once they start school, from age 1 till about 5 or 6, as many as 4 to 6 URIs per season is considered normal, right? And you can imagine that at least half of them are caused by coronaviruses. So they get this immunity built up, these kids. So when these more serious coronavirus, like when a coronavirus mutates and becomes a more serious virus, who is protected the better? The kids are, because they already have immunity. By the time you start older adolescence or adulthood, that immunity has waned off, right? And they get more prone to catching COVID-19 vaccine, and then hence more severe disease also. Kids, thank God, infect each other so much that they already have immunity against the coronavirus. Like a generic immunity against a lot of viruses they get, because they are in daycare together, they share things, they share germs. So I think it's a blessing in disguise.
Yeah, you never think about kids getting colds as being a good thing, but yeah.
Because, I tell my parents of kids who are in daycare and stuff, they get so stressed out. I said, look, you're stressed out right now, but when your child will go to school in kindergarten, he or she will not get sick way less than somebody who's like brand new to the kindergarten. Parents who keep the kids home and say, oh no, we don't want to put them in daycare because they'll get sick. I usually tell them the prime time to put them in daycare is at age 2, when their immunity is a little bit better. So then kids who stay in daycare do so much better when they're start kindergarten at age 5, because they have so much immunity built up. It's the same concept. There were some studies that showed that kids who grow up on farms have less allergies because they get exposed to all these farm animals and all the grasses and pollens and stuff. And so they have less allergies. So it's the same concept. The more you expose, it's maybe stressful for a parent, but then they get better immunity.
So speaking of parental fears, how do you deal with parents who are hesitant to vaccinate their children?
I'll be honest, it's, time consuming and stressful, but I try my best. I tell them that, look, I'm not, first of all, the parents have this fear that somehow we are forcing them. So I always say, no, you will make the decision. It is not something that I'm going to force on you or force on your child or anything. Number one. Number two, I think it helps because a lot of these parents, I know, kids, they've been coming to my practice for a while. So instead of an ER physician telling them or a pharmacist telling them, if I tell them that, and I usually try to address their concerns in a fashion which is non-judgmental. I always say, look, I understand, I'm a parent too, and these are new vaccines. This is a new virus. Well, technically it's not a new virus, but like a new mutated virus. So I tell them, I said, but they say, but doc, it's going to be okay. I mean, you just told us that it's not a serious disease in childhood. So why doesn't the child just get it and get the natural infection and just deal with it this way? And I always tell them that, look, it's fine. Your child can get the virus. Your child can still get the virus even after the vaccine. But what the vaccine does, it protects against serious infection. So whenever there is a case in the community where it makes news, some child got admitted to the ICU with a COVID-19 or something, or this Kawasaki-like syndrome, the this MCIS, then they may get a little scared. So I always give them the worst case scenario and the best case scenario, and then I let them decide. I tell them that this is a safe vaccine. It does protect your child against serious infection, against ending up in the hospital with lung disease and stuff. And I do mention the long COVID to them also. As 30% of people can develop the long COVID, in which it's kind of like infectious mononucleosis, chronic tiredness and stuff like that. Some people talk about, there are more and more studies being done on it, brain fog and stuff like that. So I tell them, I said, your child can have long COVID too, like infectious mono, in which they can be tired for a few months and they can miss out on school activities and sports, and 30% of the kids. So the key is, since everything is new here, is to talk to them in a fashion which, appeals to their, instinct to protect their child, yet does not make them feel bad about not wanting to vaccinate.
So have you seen an increased hesitancy with the COVID vaccine versus other childhood vaccines?
Oh, absolutely. Yes. Because it's a new vaccine. And whenever there is a new vaccine, it just takes longer for parents to get convinced. I remember when HPV came out, it used to take me like additional visit time of 10, 15 minutes, which we never get reimbursed for. But I felt it was important. I would tell them about that. And now there is definitely more, parents are more receptive to HPV vaccine. So it's the same thing with COVID-19 vaccine. It's a new vaccine, still being studied. So they would, and then, if you look, then they look at the bigger picture and say it's not causing young kids to die or something. So they would rather wait.
So if a pregnant mother is vaccinated for COVID-19, would her newborn be born with some level of protection?
Yes, it does protect them. How long it protects them, we don't know, because I've had some like newborns come in with mom was positive for COVID-19 just before she delivered, or was having an active infection during the delivery, and the baby is born and is checked with the antigen and the PCR and test positive. So we always tell them, it's the same thing with the flu, just make sure or if the child is, the baby is negative, we still do the contact precautions and the respiratory isolation. We say, put the face mask on, wash your hands, even though your mom is breastfeeding. So we do all of that. So it does provide some protection. But I think it has to be a few weeks before the mom delivers, when the immunity will get transmitted through the placenta. If the mom just develops an infection and then delivers, she can transmit the infection, but not the antibodies.
What are the regular vaccines that a newborn would receive?
So here there's a whole, American Academy of Pediatrics has the vaccine schedule that we all follow in the office. So when they're first born in the hospital, they get the hepatitis B vaccine. Even to moms who are hepatitis B negative, because theoretically these labs get done in the end of second trimester, so or early third trimester, and then theoretically a mom can go become Hep B positive from the time she was tested as negative to the time she delivers. So the American Academy of Pediatrics recommends that all newborns get the hepatitis B vaccine at the time of birth, even though they're born to hepatitis B negative mothers. If they're born to hepatitis B positive mothers, they get the immune globulin, the Hib H-big, and the hepatitis B vaccine. So birth, they get the hepatitis B vaccine. 2 months, they get the second hepatitis B. They get the Hib, H-flu. They get the Prevnar, PCV. They get the DTaP, diphtheria, tetanus, and pertussis, polio, and then they get the rotavirus vaccine, which is the oral vaccine. So this schedule gets repeated at 2 months, 4 months, 6 months, 9 months, they don't get anything. Then they start getting their boosters at 12 months. So the primary series for all these vaccines, like COVID-19 vaccine, has 3 primary series vaccines. Similarly, all of these vaccines for newborns, 3 primary vaccines, and then they start getting boosters at age 12. So they get repeated all of these, and they also get the MMR and chickenpox at age 12 months, and then 15 months, they're pretty much done. And then second set of boosters is given at age 4 years or 5 years before starting kindergarten. You want to give them boosters before they start back together, en masse and start infecting each other.
Right. Okay, so would you be willing to answer a few questions about your career path?
Sure, absolutely.
What was it that drove you to choose a pediatric residency?
So I'm actually, I grew up in Pakistan, and but I went to medical school there also. And right from the time I was doing clinicals, pediatric medicine has always fascinated me. I just enjoy working with kids, more. To me, it was always more rewarding. And of course, the patients are much cuter. And so I did my pediatric internship in pediatrics in Pakistan after medical school. And then when I moved to USA and I did my, you have to pass exams again to be able to start residency program. So I had no hesitation in choosing pediatrics because I had felt it was very gratifying for me. I enjoyed it. I felt more rewarded. And then I'm not saying adult medicine is not rewarding. I'm sure it is. But for me personally, the choice was clear. I enjoyed working with little ones. So that's what I chose. So I think it was more of a personal choice, and I'm very, very happy that I made that choice.
Can you walk us through what a normal day in your job would look like?
Sure. So I have my own pediatric practice in Ocala, Florida. A lot of kids who are graduate. I think your audience is mostly kids who are going to start residency, right?
Yeah, people who are interested in starting medical school.
Oh, starting medical school. Okay, got it. So I would recommend that all kids who are going to start medical school, the best time to decide about these things is when you start your clinical rotations. You get to interact with different specialties and see what they like. For me, after I did my pediatric residency, the choice was joining a big group or having my own practice. And I chose the latter because I felt like I could get more autonomy and could set my own, I shouldn't say like clinical hours and stuff, but I was just, more flexibility for me. So I decided to start my own practice, and I've had it for 24 years in Florida now. The typical day for me is, I start my patients around 9, in the morning. I used to go to the hospital before, like from 8 to 9, I would go to the hospital and then go to the office. But there is an upsurge of pediatric hospitalists in all the US hospitals now. So a lot of kids who graduate from residency programs end up becoming hospitalists. So I don't go to the hospital anymore. The pediatric hospitals take care of my patients. And when they get discharged, then I see them. So my typical day starts at 9. I usually see patients, I have one patient scheduled every 15 minutes. And then it's split half and half are well visits. A big bulk of pediatric practice, outpatient practice is, as you know, is sick visits and well visits. Well visits are, we follow the recommendation of the American Academy of Pediatrics of how often we need to see. And then a third part of my practice is behavioral medicine. I'm in a smaller town in Florida, and even in big towns across the country, there's a dearth of pediatric psychiatrists. So a lot of kids fall through the cracks who need help with ADHD and behavioral issues and depression and anxiety, especially an upsurge of depression and anxiety because stemming from the COVID-19 pandemic and the kids being homebound for 2 years. So there's been an increase in number of cases of that. So the third part of my practice comprises of the behavioral medicine. I do treat ADHD in my practice, anxiety, depression. Anything beyond that, like, more serious issues like bipolarity, I can diagnose, but then I set them up to see psychiatrists so they can be, followed more closely with there. So I basically don't do counseling in my office for pediatric. If you're a pediatrician, the way the medicine is set up in this country, we don't get paid for doing any type of therapy. So and plus I feel like I personally lack the training to do that. So what I do is I send them to get therapy from outpatient therapists, and I take care of the medicine part of it. And if at any point I feel like the child is deteriorating or the family requests it, I send them to a psychiatrist. But the wait to see a psychiatrist is so long that the patients end up coming back to me, and I take care of them until they can get situated.
Yeah, that's hugely important because I know some pediatric psychiatry programs that were more intensive have closed because of COVID, and then people are like 80 on a waiting list. And like, if you don't deal with these issues when they're young, it's only going to be worse.
It's a tremendous I was shocked to see that I had like 12-year-old kids come in with suicidal thoughts, 11-year-olds coming in with suicidal thoughts. And of course it has to do with COVID also, but it also has to do with increase in social media usage and lack of personal interaction between kids.
So besides these psychiatric concerns, what are some of the biggest healthcare concerns that you think are facing pediatric populations right now?
I think another big one that people don't talk about enough is obesity in pediatrics. Again, remember, it's all tied in. I always talk about a healthy body leads to a healthy mind and vice versa. So when kids are depressed, they're homebound, they were not going outside. The parents were working. So it was a very, very sad period in kids, for pediatrics. And of course, don't forget that there were so many special needs kids who could not get out and get the education they needed. So they fell behind academically. They fell behind socially. And a lot of these kids could get therapies in school. So they were not able to get it because parents can't take them to these therapies. So they were getting it in schools. And, not to mention the nutritional deprivation. A lot of these kids would get breakfasts and lunches at school. So that's a whole new topic that I can talk about next time. But right now, the most important thing, the thing that bothers me is the lack of physical education and lack of physical activity in our pediatric population. And I think it has to do with the change in social conditions in our society. Before, if you watch all the movies in the 50s and 60s and even 70s, the mothers wearing nice dresses would get the kids off the bus, right? So when the kids got home, there was a parent there who would, give the kids healthy snacks. The society was the general societal expectation was that the kids would be outside more. It was a safer place. Kids could play outside without the parents worrying about the kids getting abducted and stuff like that. So the social fragmentation that has happened in our society and economic fragmentation has led to both the parents working. And when that happens, when the kids get off the bus, you're 12, 13, 14 years old, they go home, the parents don't get home for another 2-3 hours. So what do the kids do? And they're not allowed to go outside. And I don't blame the parents for making sure the kids stay indoor until the parents get home. So what happens? They're on their phones, right? Or on their laptops. So screen time, less physical activity. And then they get hungry. So they'll raid the pantry and they will eat chips and cookies and who knows what. And then by the time the parents get home, the parents have to, it's a rushed environment. The parents have to, the moms and the dads have to cook food for the kids, get them ready, get them tucked in, the homeworks and stuff like that. So I think it's the societal fragmentation and the least, the most vulnerable population is the kids. So unless as a society we decide, okay, we are going to give this aftercare for all kids whose parents are working, they can stay in school. Like a lot of European countries do that. The kids can get dropped off in the morning and they get picked up and the parents get out. So they are still under adult supervision. They can still go outside and, be physically active. They get healthy snacks. So that part is missing in our society. So we have to step up to it. We have to take charge and say, okay, this is it. We need to do this. Unless that happens, obesity. And, of course, then I'm finding higher and higher hemoglobin A1Cs in my pediatric patients. I'm finding higher total cholesterols and HDL and triglycerides are increasing. And because they're not going outside in the sun, their vitamin D levels are low. So there's a whole slew of problems that arises because of that. So I hope and pray that we get more into this, more of a universal aftercare situation in which the parents don't feel so guilty and the kids are not splurging on unhealthy snacks and less screen time. That is really, really most critical right now.
So on a lighter note, my last question is, what's the most fulfilling part of your job?
The most fulfilling part is, interacting with the acute patients. They're so friendly and they're so, they say whatever comes in their mind. They rush in, they hug me and they ask me for a lollipop. I tell them, okay, I'll give you a lollipop, but first you have to open your mouth and let me check your ears and throat. So they'll sit there quietly. They will do exactly what I tell them to do. And they'll cry a little bit, but they won't complain when they get vaccines or they get their throat swabbed. They will cooperate. And then when they're leaving, they say, we forgive you, Dr. Q, as long as you give us a lollipop. So then we hug each other. I take them to the front desk and they get their lollipop and their stickers and they're home. So it's just a very, very gratifying part of helping kids. And with pediatrics, majority of the ailments are, curable, right? You can cure ear infection, you can cure throat infection, you can deal with so many things and which makes them feel better. And they like that versus, dealing with chronic conditions like diabetes and hypertension and stuff.
I'm glad to hear the lollipop tradition is still going strong.
Oh, absolutely. You can't you can't run a pediatric practice without that.
Thank you so much for taking time to mentor us today. This was an extremely informative session on a lot of really relevant topics for today.
Absolutely. My pleasure.
Yeah, I invite everyone to share their thanks in the chat. And I'll pass it over.
Thank you so much. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live, and as always, you'll need a 70% or higher to pass and receive certification. And the link to the quiz is being sent in the chat now. And for our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, October 8th at 10 a.m. Eastern Standard Time with our physician mentoring us in psychiatry. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.
Thank you. Bye.